Okay, so Assalamu alaikum everyone. My name is Dr. Batul Zahra, and today in partnership with Medical Hub Academy, I'm going to give the lecture on the topic adrenergic antagonist, which is also known as sympatholytics. So as we have discussed in the last lecture, that sympathomimetics are the drugs which mimics the action of sympathetic system. Sympatholytics actually work in the reverse, right? So that's why they're called as sympatholytic, because they block or decrease the effects of sympathetic nervous stimulation, endogenous catecholamines, and adrenergic drugs. So guys, over here, you can see that there are two types of anti-adrenergic drugs. So obviously, as we have studied in the last class, that there are alpha receptors and beta receptors on the prosynaptic membrane. So when we study about the adrenergic antagonist, obviously the drugs will be going to working on both receptors. So drugs which are going to be alpha antagonists are again two types. They are either the selective alpha blockers or non-selective alpha blockers. So when we study about the selective alpha and non-selective alpha blockers, we can see over here that there are two types of drugs which are non-selective, and they are phentolamine and phenoxybenzamine. And when you talk about the alpha-1 antagonists, which are selectively working on only alpha-1, these are doxazosin, prazosin, terazosin, and pantalosin. Over here, we can easily remember the suffix "sin", and whenever the suffix "sin" comes in any drugs, we can recognize that these are selective alpha-1 blockers. So we have doxazosin, prazosin, terazosin, and pantalosin. Okay, next, we have beta blockers. And over here, we can again see that beta blockers are again divided into two types: beta selective blockers and beta non-selective blockers, right? So all the medicines which start from the letter A to the letter M, except the letter C, are the selective beta blockers. For example, over here you can see that all the drugs, okay, let me just annotate so that you can understand from here. Drugs starting from the letter A to M, okay, except C. These all the drugs will be beta-1 blockers. So acebutolol, atenolol, betoxolol, bisoprolol, esmoprolol, metoprolol, these all are beta-1 blockers. And when I say except C, so drugs coming from the letter C like cartiolol, carvedilol are non-selective. So basically what happened is that these drugs, okay, which are starting from the letter M to obviously Z, all of these drugs are going to be the non-selective beta blockers along with the letter C. So as you can see over here, labetalol, natolol, pambutolol, pindolol, propranolol, sotalol, timolol, all of these are coming after the letter N or from the letter N, right? So you can easily remember that these drugs are going to be beta non-selective blockers. And when I say except the letter C, Over here, you can see that it is catolol or carvedilol, right? Now, one more interesting thing over here, that you can see that there is an asterisk made in front of carvedilol and labetalol. So this is because these drugs will not only going to work on beta receptors, but along with that, it will also going to work on alpha receptors. So basically, these are the non-selective alpha and beta blockers both. So it will going to work on alpha 1 plus 2 along with beta 1 plus 2, right? So that's why they are, sorry, alpha 1 blockers along with beta 1 and beta 2 blockers. And as we all know that labetalol is most commonly used to control the hypertensive emergency, right? Okay, moving further. Now, once again, propranolol, which is the non-selective one with the marker of indole, is highly lipid soluble. And let's revise the therapeutic uses of propranolol or indole. It is used in hypertension, angina pectoris, cardiac arrhythmias, myocardial infarction, and migraine headache. If you remember, for the prophylactic use before the acute attack, not during the attack. Okay. And the adverse effects of indole will be referred to previous adverse effects. In addition to CNS effects, there will be depression and insomnia, nightmares and hallucinations, and used with here in patients with a history of depression. So as the propranolol can cause depression, we're going to use it very carefully if a patient has history of it. And now the precautions and contraindications should be avoided in patients with a history of anaphylaxis. Obviously, anaphylaxis is basically a history of allergic attack and must be used with caution for diabetic patients because it suppresses the glycogenolysis. And if the glycogenolysis is going to be suppressed, there will be high amount of sugars in our blood, which will be very dangerous for diabetic patients. It also masks tachycardia, and warn the patient that tachycardia is no longer an indication of hypoglycemia. And it should be taught alternative signs like sweating, hunger, fatigue, and poor concentration. Now, we're going to study about the drug interactions. Propranolol can interact with calcium channel blockers. It also has cardiac effect of certain calcium channel blockers, example verapamil. So it is identical to those of propranolol. Over here, we should be remembered that if we are giving propranolol to a patient, never ever combine it with verapamil. Otherwise, there will be sudden decrease in blood pressure and impeded early recognition of insulin-induced hypoglycemia. So the dosage must be adjusted by monitoring the patient response and not by relying on dosing information in a drug reference. Because as you know that every patient is different and every patient has own comorbidities. So we are not going to rely entirely on the pamphlet which comes along with the drug. Try to study the case of the patient and get each and every dose according to his or her signs and symptoms. Now we have metoprolol. So metoprolol is a selective beta blocker and it's specially cardioselective agent, and it's preferred for patients with asthma or diabetes because it is not working on beta 2 receptors. It's only working on beta 1 receptor. So it is also used for hypertension, angina pectoris, myocardial infarctions, and it is very suitable if a patient who comes with asthma or history of diabetes and suffering from hypertension, MI, or angina. So you can give her or him metoprolol, which came with the market name of Mirol. And it also deprives the diabetic patient of early indication of hypoglycemia. Next, we have pindolol. Pindolol is a non-selective beta blocker. It's actually it has partial agonist activity, and so it will going to increase the intrinsic sympathomimetic activity. Binding to receptors produce limited degree of receptor activation while preventing strong agonists from binding to the receptor to cause full activation. Have very little effect on resting heart rate and cardiac output and pressure preferred for the patient with bradycardia and contraindicated in MI. So basically what happened is that pindolol is basically a competitive blocker, and when it is going to bind the beta 1 and beta 2 receptors, so it has a very limited response. Instead, we're going to compete with the beta agonist, and it will stop them for having full activation. So basically, we're calling it a partial agonist, right? And over here, the most important point to remember is that it is contraindicated in MI. So that's all about the adrenergic antagonist. And if you have any sort of question, please let me know. Thank you so much.